Hello friends, I am Dr. R.L. Tiwari with an interesting and learning episode of B Pharma on the important unit of opioid analgesics, which is a very important unit of the section of Medicinal Chemistry 2 of 6th semester. Let us start our episode while taking a look at what we are going to learn today. Module 1, Introduction to Opioid Analgesics. Module 2, Opioid Receptors. Module 3, Morphine and Related Drugs. Module 4, Chemistry and Synthetic Modifications of Morphine, Codeine and Thebaine. Module 5, Totally Synthetic Analgesics Part 1. Module 1, Introduction to Opioid Analgesics. Let us start with general introduction about analgesics and opioid analgesics. Analgesic, a drug that selectively relieves pain by acting in the central nervous system (CNS) or on peripheral pain mechanisms without significantly altering consciousness. Analgesics relieves pain as a symptom without affecting its cause. Analgesics are divided into two groups such as A. Opioid or narcotic or morphine-like analgesics, B. Non-opioid, non-narcotic or aspirin-like or antipyretic or anti-inflammatory analgesics. Opioid analgesics. The term opioid refers to all compounds related to opium. Opium is obtained from the poppy, Papaver somniferum and Papaver album. After the incision, the poppy seed pod capsule exudes a white substance that turns into brown gum, that is crude opium. Figure 1 shows opium poppy plant and opium collection. Opium contains two types of alkaloids. Number 1, phenanthrene derivatives. These are morphine 10% in opium, analgesic; codeine 0.5% in opium, analgesic; thebaine 0.2% in opium, non-analgesic. Number 2, benzoisoquinoline derivatives. These are papaverine 1% non-analgesic, noscapine 6% non-analgesic. Figure 2 shows morphine and papaverine structures. Module 2, Opioid Receptors. Morphine and other opioids exert their actions by interacting with specific receptors present on neurons in the CNS and in peripheral tissues. Chemical modifications of morphine structure has yielded a number of compounds which have a complex pattern of morphine like other agonistic and antagonistic actions that cannot be explained on the basis of a single opioid receptor. Radioligand binding studies have divided these opioid receptors into three types: mu, kappa and delta, which have been cloned. Each has a specific pharmacological profile and pattern of anatomical distribution in the brain, spinal cord and peripheral tissues. Subtypes of mu and kappa receptors have been identified. The proposed functional role of three types of opioid receptors is shown below in table 1. Table 1, actions ascribed to different types of opioid receptors, mu, kappa and delta. Now, mu, analgesia, supraspinal mu1 and spinal mu2, respiratory depression mu2, sedation, euphoria, meiosis, reduced GI motility mu2, physical dependence, morphine type. Now, kappa, analgesia, spinal kappa 1, supraspinal kappa 3, respiratory depression, lower ceiling, dysphoria, psychotomimetic, meiosis, lower ceiling, sedation, physical dependence, nalorphine type, reduced GI mortality. Delta, analgesia, spinal and affective component of supraspinal, respiratory depression, affective behavior, reinforcing actions, reduced GI motility. Opioid ligands can interact with different opioid receptors as agonists, partial agonists or competitive antagonists. The overall pattern of effect of a particular agent depends not only on the nature of its interaction with different opioid receptors, but also on its relative affinity for those. For example, morphine is an agonist on mu, kappa and delta receptors, but its affinity for mu receptors is much higher than that for the other two. The effects therefore are primarily the result of mu receptor activation. The nature and intensity of action of complex action opioids and antagonists are summarized in table 2. Table 2 shows nature of interaction of opioid ligands with the three major types of opioid receptors along with equivalent analgesic doses. Ligands. Number 1, morphine. Its action on mu receptor is agonist strong. Its action on kappa receptor is agonist weak. Its action on delta receptor is agonist weak with the analgesic dose of 10 milligrams. Number 2, nalorphine. Action on mu receptor, antagonist strong. Action on kappa receptor, agonist moderate. No action on delta receptor. Number 3, pentazocine. Partial agonist, antagonist weak. Action on kappa receptor, agonist moderate. No action on delta receptor. Dose 30 to 60 milligrams. Number 4, butorphanol. Action on mu receptor, partial agonist weak. Action on kappa receptor, agonist strong. No action on delta receptor. Dose 1 to 3 milligrams. Number 5, buprenorphine. Action on mu receptor, partial agonist. Action on kappa receptor, antagonist moderate. No action on delta receptor. Dose 0.3 to 0.4 milligrams. Number 6, naloxone. Action on mu receptor, antagonist strong. On kappa receptor, antagonist moderate. On delta receptor, antagonist weak. Number 7, naltrexone. Action on mu receptor, antagonist strong. Action on kappa receptor, antagonist strong. Action on delta receptor, antagonist weak. Mu receptor. The mu receptor is characterized by its high affinity for morphine. It is the major receptor mediating actions of morphine and its cogeners. Endogenous ligands for mu receptors, peptides called endomorphins 1 and 2 have recently been found in mammalian brain. Produced biological effects ascribed to this receptor. Two subtypes of mu receptors have been proposed. Mu1 has high affinity for morphine, mediates supraspinal analgesia and is selectively blocked by naloxonazine. Mu2 has lower affinity for morphine, mediates spinal analgesia, respiratory depression and constipating action. Kappa receptor. The kappa receptor is defined by its high affinity for ketocyclazosine and dynorphin A. This latter is considered to be its endogenous ligand. Two subtypes of kappa receptors K1 and K3 are functionally important. Analgesia caused by kappa agonists is primarily spinal. through kappa-1 receptor. Delta receptor. This receptor has high affinity for Leu/Met enkephalins, which are the endogenous ligands. The delta mediated analgesia is again mainly spinal. Delta receptors are present in dorsal horn of a spinal cord, but the effective compound of supraspinal analgesia appears to involve delta receptors because these receptors are present in limbic areas, also responsible for dependence and reinforcing actions. Opioid receptor transducer mechanisms. All three types of opioid receptors, mu, kappa and delta, have been cloned. All are G protein coupled receptors located mostly on prejunctional neurons. They generally exercise inhibitory modulation by decreasing release of the junctional transmitter. See figure 3. As such, various monominergic Na, DA5, HT, GABA, glutamate, NMDA/AMPA pathways are intricately involved in opioid actions. Opioid receptor activation reduces intracellular cyclic AMP formation and opens K+ channels mainly through mu and delta receptors, or suppresses voltage gated N-type calcium 2+ ion channels, mainly kappa receptor. These actions result in neuronal hyperpolarization and reduced availability of intracellular calcium ion decreased neurotransmitter released by CNS and mycentric neurons. For example, glutamate from primary nociceptive afferents. Figure 3 shows opioid receptor transducer mechanism. Module 3, Morphine and related drugs. Dear friends, before starting this module, we should have an idea about classification of opioids. Classification of opioids. Firstly, natural opium alkaloids. Examples are morphine and codeine. Secondly, semi-synthetic opiates. Examples are pholcodine, diacetyl morphine, heroin. Some others are hydromorphone, oxymorphone, hydrocodone and oxycodone. Next is synthetic opioids. Examples are pethidine, which is also known as meperidine, fentanyl, methadone, propoxyphene, tramadol, and some others are levorphenol, dextromoramide, dipypanone, alfentanil, sufentanil, and remifentanil. Morphine. Morphine is the principal alkaloid in opium and is still widely used. Its structure is already shown in figure 2. Now, pharmacological actions of morphine. CNS. Morphine has site-specific depressant and stimulant actions in the CNS by interacting primarily with the mu opioid receptor as a full agonist. The depressant actions are firstly as analgesic. Morphine is a strong analgesic. Though dull, poorly localized, visceral pains is relieved better than sharply defined somatic pains. Higher doses can mitigate even severe pains. Degree of analgesia increases with dose. Nociceptive pain arising from stimulation of peripheral pain receptors is relieved better than neurotic pains. Next is sedation. Higher doses progressively induce sleep and coma. Morphine has no anticonvulsant action, rather fits may be precipitated. Next is mood and subjective effects. Morphine has calming effect. There is loss of apprehension, feeling of detachment, lack of initiative, limbs feel heavy and body warm, and inability in concentration occurs. Next is respiratory center. Morphine depresses respiratory center in a dose dependent manner. Rate and tidal volumes are both decreased. Next is cuff centers. It is depressed, more sensitive to morphine than respiratory center. Temperature regulating center. It is depressed. Hypothermia occurs in cold surroundings. Next is vasomotor center. It is depressed of higher doses and fall in BP observed. Morphine stimulates CTZ. Nausea and vomiting occurs as side effects. Edinger-Westphal nucleus of third nerve is stimulated, producing meiosis. Next is Vogel center. It is stimulated. Brachycardia is the usual response. Cortical areas and hippocampal cells are stimulated. Convulsions may occur in morphine poisoning. Neuroendocrine. Hypothalamic activation by afferent collaterals is dampened. Hypothalamic influence on pituitary is reduced. As a result, FSH, LH, ACTH levels are lowered. Next is CVS. Morphine causes vasodilation due to histamine release, depression of vasomotor center, direct action decreasing tone of blood vessels. Next is GIT. Constipation is a prominent feature of morphine action. Next is other smooth muscles. Biliary tract may cause biliary colic. Urinary bladder, urinary urgency seen. Uterus may slightly prolong labor. Bronchi can cause bronchoconstriction. ANS, it has weak anticholine esterase action. Now we will come to the pharmacokinetics of morphine. The oral absorption of morphine is unreliable because of high and variable first pass metabolism over bioavailability is 1/6 to 1/4 of parenterally administered drug. Distribution is wide. Concentration in liver, spleen and kidney is higher than that in plasma. Only a small fraction enters in brain rather slowly. Morphine freely crosses placenta and can affect the fetus more than the mother. It is primarily metabolized in liver by glucuronide conjugation. Morphine 6-glucuronide is an active metabolite and contributes to analgesia. Another metabolite, morphine 3-glucuronide, has neuroexcitatory property. Plasma T-half of morphine averages 2 to 3 hours. Effect of parenteral dose lasts 4 to 6 hours. Elimination is almost complete in 24 hours and morphine is non-cumulative. Now we will come to adverse effects of morphine. Firstly, side effects: sedation, mental clouding, vomiting, respiratory depression, blurring of vision, urinary retention. Allergy. Allergy is uncommon and anaphylactoid reaction is rare. Next is apnoea. This may occur in the newborn when morphine is given to the mother during labor. Morphine poisoning. It is accidental, suicidal, or seen in drug abusers. In non-tolerant adult, 50 milligrams of morphine intramuscular produces serious toxicity. The human lethal dose is about 250 milligrams. Stupor or coma, flaccidity, shallow and occasional breathing, cyanosis, pinpoint pupil, fall in BP and shock. Convulsions may be seen in few. Pulmonary edema occurs at terminal stages. Death is due to respiratory failure. Now treatment, this consists of respiratory support, that means positive pressure respiration also decreases pulmonary edema formation, and maintenance of BP, that means fluids, vasoconstrictors. Gastric lavage is recommended even when morphine has been injected. Now antidote, naloxone 0.4 to 0.8 milligram intravenous, repeated after every 2 to 3 minutes till respiration picks up. Injection should be repeated after every 1 to 4 hours, later on according to the response. Tolerance and dependence. Higher degree of tolerance can be developed to morphine and related opioids. If the drug is used repeatedly, morphine produces prolonged psychological and physical dependence. Its abuse liability is rated high. Now treatment. This consists of withdrawal of morphine and substitution with oral methadone, long-acting orally effective, followed by gradual withdrawal of methadone. However, relapse rate among post-addicts is high. Dose 10 to 50 milligrams oral, 10 to 15 milligrams intramuscular or subcutaneous, or 2 to 6 milligram intravenous, 2 to 3 milligrams epidural or intrathecal. Children 0.1 to 0.2 milligrams per kg. Now we'll come to next member, that is codeine. It is methyl morphine, occurs naturally in opium and is partly converted in the body to morphine. It is less potent than morphine, 1/10 as analgesic, also less efficacious. It is a partial agonist at mu opioid receptor with a low ceiling effect, can relieve mild to moderate pain only. Codeine is more selective cough suppressant, only 1/3 as potent as morphine. Subanalgesic doses 10 to 30 milligram suppresses cough. The analgesic action has been ascribed to morphine generated by its demethylation by CYP2D6. Codeine fails to produce analgesia in subjects with polymorphic CYP2D6. However, receptors involved in antitussive action appears to be distinct because they bind codeine as well as morphine. Codeine has good activity by the oral route. Oral parenteral ratio 1:2. A single oral dose acts for 4 to 6 hours. Constipation is a prominent side effect when it is used as analgesic. Codeine has been used to control diarrhea. The abuse liability is low. Figure 4 represents structure of codeine. Now we will come to next member, that is Folcodeine. It has codeine-like properties and has been used mainly as antitussive, claimed to be less constipating. Figure 5 shows the structure of pholcodeine. Now we will come to next member, which is heroin, diamorphine, diacetylmorphine. It is 3 times more potent than morphine, more lipid soluble, enters brain more rapidly, but duration of action is similar. It is more euphoriant, especially on intravenous injection, and highly addictive. Because of its high potency, it has been favored in illicit drug trafficking. The sedative, emetic and hypotensive actions are said to be less prominent. It has no outstanding therapeutic advantage over morphine and has been banned in most countries except UK. Now figure 6 represents the structure of diacetylmorphine. Now we will come to uses of morphine and its cogners as analgesic. Opioid analgesics are indicated in severe pain of any type. However, they only provides symptomatic relief without affecting the cause. Morphine or one of its parenteral cogners is indicated in traumatic visceral ischemic, that means myocardial infarction, postoperative, burns, cancer pain and the like. It should be given promptly in myocardial infarction. Opioids, especially pethidine, have been extensively used for obstetric analgesia, but one must be prepared to deal with the fetal and maternal complications. Neuropathic pain responds less predictably to opioid analgesics. For milder pain, for example toothache, headache, neuralgias, etc., codeine or dextropropoxyphone may be used orally either alone or in combination with aspirin-like drug. Secondly, pre-anesthetic medication. Morphine and pethidine are used in few selective patients. Next is balanced anesthesia and surgical anesthesia. Fentanyl, morphine, pethidine, alfentanil or sufentanil are an important component of anesthetic techniques. Relief of anxiety in myocardial infarction, internal bleeding, hematemesis, threatened abortion. Morphine or pethidine have been employed. Acute left ventricular failure, that is cardiac asthma. Morphine intravenous affords dramatic relief in cardiac asthma. Cough, codeine or its substitutes are widely used for suppressing dry, irritating cough. Diarrhea. Codeine has been used to check diarrhea and to increase consistency of stool. Now we will come to our next module, which is module 4, chemistry and synthetic modifications of morphine, codeine and thebaine. The structure of morphine is shown below. Figure 7 shows the structure of morphine molecule. Many semi-synthetic derivatives are made by simple modifications of morphine or thebaine. Codeine is methyl morphine, the methyl substitution being on the phenolic hydroxyl group. Thebaine differs from morphine only in that both hydroxyl groups are methylated and that the ring has 2 double bonds at carbon 6-7 and carbon 8-14 positions. Thebaine has little analgesic action but is a precursor of several important 14-OH compounds such as oxycodone and naloxone. Diacetylmorphine or heroin is made from morphine by acetylation at 3 and 6 positions. Apomorphine, which can be prepared from morphine, is a potent emetic and dopaminergic agonist. Hydromorphine, oxymorphone, hydrocodone, oxycodone also are made by modifying the morphine molecule. Now we will come to structural activity relationships. The phenolic OH, a free phenolic group, is crucial for analgesic activity. Methylation on the phenolic OH group, the analgesic activity drops drastically and the resultant codeine is only 0.1% as active as morphine. Codeine is the methyl ether of morphine and used for treating moderate pain, coughs and diarrhea. This drop in activity is observed in other analogues containing a masked phenolic group, alcoholic group. Figure 9 shows the effect of substitution at alcoholic OH on analgesic activity. Masking or the complete loss of the alcoholic group does not decrease analgesic activity. So, 6-alcoholic group is not crucial for analgesic activity of morphine. The N-methyl group, figure 10, shows the effect of substitution at N-methyl group on analgesic activity. The nitrogen itself is crucial, and if it is removed completely, all analgesic activity is lost. The replacement of the N-methyl group with a proton reduces activity but does not eliminate it. The N-oxide and the N-methyl quaternary salts of morphine are both inactive. The secondary NH group is more polar than the tertiary N-methyl group and therefore finds it more difficult to cross the blood-brain barrier, leading to a drop in activity. Next, the aromatic ring. The aromatic ring is essential. Compounds lacking it show no analgesic activity. The ether bridge. As we shall see later, the ether bridge is not required for analgesic activity. Dear friends, up till now you have gained an idea about natural opium alkaloids and their semi-synthetic derivatives. Now we shall learn about some synthetic analgesics in module 5. Now we will come to module 5, totally synthetic analgesics, part 1. Morphine. Morphine is the prototype chemical structure of a large chemical class of psychoactive drugs consisting of opiate analgesics, cough suppressants and dissociative hallucinogens. Among others, figure 11 shows the structure of morphine. Chemical formula C16H21N, molar mass 227.35 grams per mole, density 1.56 grams cubic centimeter, boiling point 115 plus minus 0.05 degrees Celsius in liquid oil. Morphine has a phenanthrene core structure with the A ring remaining aromatic and the B and C rings being saturated, and an additional nitrogen containing 6-membered saturated ring, the D ring, being attached to carbons 9 and 13 of the core and with the nitrogen at position 17 of the composite. N-methyl morphine grew in 1946, approached the problem of synthetic analgesics as when he synthesized the tetracyclic compound that he first named morphine and then revised to N-methyl morphine. Figure 12 shows the structure of N-methyl morphine. N-methyl morphine differs from the morphine nucleus in lacking the ether bridge between C4 and C5. This compound possesses a high degree of analgesic activity, which suggests that the ether bridge is not essential. 3-hydroxy N-methyl morphin or levorphenol. Figure 13 shows the structure of 3-hydroxy N-methyl morphin or levorphenol. Levorphenol, brand name is levodromuron. It is an opioid medicine used to treat moderate to severe pain. Chemically it is levo 3-hydroxy N-methyl morphin. It is the levo stereoisomer of racemorphen, first discovered in Germany in 1948 as an orally active morphine-like analgesic. Levorphenol acts as an agonist of the mu-opioid receptor, but is also an agonist of the delta opioid, kappa opioid and nociceptin receptors, as well as NMDA receptor antagonist and a serotonin norepinephrine reuptake inhibitor. Levorphenol, similarly to certain other opioids, also acts as a glycine receptor antagonist and GABA receptor antagonist at very high concentrations. Relative to morphine, levorphenol lacks complete cross tolerance and possesses greater intrinsic activity at the MOR. The duration of action is generally long compared to other comparable analgesics and varies from 4 hours to 15 hours. For this reason, levorphenol is useful in treatment of chronic pain and similar conditions. It has an oral to parenteral effectiveness ratio 2:1, which is most favorable of the strong narcotics. It is very effective against neuropathic pain. Levorphenol is listed under the Single Convention on Narcotic Drugs 1961 and is regulated like morphine in most countries. Now we will come to next member, which is benzomorphin or 6,7-benzomorphin. Figure 14 shows the structure. Chemical formula is C12H15N. Molar mass 173.25 grams per mole. Benzomorphin is a chemical compound. It is the base for a series of drugs which variably act on the opioid and sigma receptors, including the following compounds: 5,9-DEHB, 8-CAC, elazosine, anazosine, bremazosine, butinazosine, carbazosine, cogazosine, cyclazosine, dazosine, pentazosine, ethazosine, eptazosine, etc. Some of these agents are used as analgesics, including pentazosine, phenazosine, dazosine, and eptazosine. Summary: the active principle of opium is morphine, and this compound is one of the most effective painkillers available to medicine. It is especially good for treating dull, constant pain rather than short, periodic pain. It acts in the brain and appears to work by elevating the pain threshold, thus decreasing the brain's awareness of pain. The receptor activation reduces intracellular cyclic AMP formation and opens potassium ion channels or suppresses voltage gated and N-type calcium 2+ channels, mainly kappa receptors. These actions result in neuronal hyperpolarization. Unfortunately, it has a large number of side effects, include depression of the respiratory center, constipation, excitation, euphoria, nausea, pupil constriction, tolerance, dependence. Chemical modifications of morphine structure has yielded number of compounds which have complex patterns of morphine-like analgesics and antagonistic actions. With all these information here, we come to end of today's lecture. Do keep in mind what we discussed today. This is Dr. R.L. Tiwari signing off. I shall be back with one more lecture in this series, which is totally synthetic analgesics part 2. Till then, keep studying. Goodbye.